Good afternoon, everyone. My name is Michael Richai, and today I'll be presenting on gene therapy for spinal muscular atrophy, or SMA, which is a new disease that's going through a recent pipeline change with different possibilities that are presenting milestones. So let's get into what SMA actually is. So spinal muscular atrophy is a rare autosomal recessive neuromuscular disease. This means a child has to inherit a defective gene from both parents to develop the condition. Specifically, SMA is caused by a biallelic deletion or mutation of the survival motor neuron 1, or the SMN1 gene, specifically located on chromosome 5q. And when this gene is missing or non-functional, the body cannot produce enough of that protein, which is essential for the survival of motor neurons, which are the nerve cells in our spinal cord that control voluntary muscular movements. Without it, motor neurons progress degeneratively, leading to muscle atrophy and weakness. Important, SMA is the most common genetic cause of infant death, which is why the development of new treatments is so critical. Yeah, so SMA is classified into four types based on age of onset and the highest milestone achieved, with type 1 being the most severe. It presents in before 6 months of age, where the children never learn to sit independently, and without treatment, only 8% survive beyond 20 months without permanent ventilation. Then there's type 2, which is the intermediate, appearing between 6 to 18 months. The children learn to sit but never stand independently, and they can survive into adulthood, but they do have significant disabilities. And then type 3, a mild form, presenting after 18 months, where children or patients can walk independently, but may gradually lose their ability that over time, but they do have a near normal lifespan. And type 4, which is the adult onset of usually around 21 years age or older, they walk independently, but they may gradually have like a mild weakness, and that they do have a normal lifespan, just like type 3. And the key modifier of this disease's severity is the number of the copies of the backup gene called SMN2, which means that they have more copies of the SMN2 gene. That means it's usually got a milder phenotype. And because SMN2 can produce small amounts of functional protein, that can help determine like the classification in which they fall into sometimes as well. So now let's walk through the pathophysiology step by step. The diagram shows the complete motor pathway from the brain to the spinal cord, down the motor neuron axon, across the neuromuscular junction, and finally into the skeletal muscle. And SMA, the problem starts here in the spinal cord, where the alpha motor neurons in the anterior horn, which are the cells responsible for sending the signals to the muscles, begin to degenerate because they lack that specific SMN protein. And as those motor neurons die, the connection between the nervous system and the muscle is lost. So this pathway is lost here. The muscles become denervated and progressively atrophy, and then in severe cases, even the sensory neurons and the proprioceptors here can be affected, essentially cutting off that feedback. Now looking at the molecular level, we're going to look at these three panels. Panel A shows the situation where the SMN1 gene produces a full-length SMN protein and an SM2 contributing a small amount as well. Panel B is showing what happens in SMA. The patient is entirely dependent upon SM2 because the SMN1 protein is not, or gene is not there. And that's the problem. SM2 has a single nucleotide difference, and it's down to a cytosine to a thiamine substitution at position 6 on axon 7. This seemingly small change causes the splicing machinery to skip exon 7 in about 90% of transcripts. The resulting protein is truncated, unstable, and rapidly degraded. So SMN2 can only produce about 10% of the functional protein, not nearly enough to keep the motor neuron alive. And then panel C, I won't really get into because this is how therapeutic approaches right now, because these involve antisense oligonucleotides or small molecular splicing modifiers that I'll get more into later. Without adequate SMN protein, the alpha motor neurons in the anterior horn of the spinal cord begin to degenerate. You can see in this diagram the comparison between a healthy infant and an infant with SMA. On the left, the motor neuron is healthy, the axon's intact, the neuromuscular junction is functioning normally. And then on the right over here, you see that the motor neuron is degenerating, the neuromuscular junction is breaking down, and then the skeletal muscle is beginning to atrophy. So the motor neurons are uniquely vulnerable to SMN deficiency because they are extremely high demands for RNA processing here that play a critical role in assembling the molecular machinery needed for that specific process, and the progressive loss of these motor neurons leads to the denervation of the muscles they supply. Once the motor neurons are lost, the muscles they innervate undergo progressive atrophy. A key clinical feature is the proximal muscles. The closer to the trunk, like the shoulders and the hips, are affected more severely than the distal muscles, like the hands and the feet. And then the most severe form, which is type 1, this leads to respiratory failure because the intercostal muscles weaken while the diaphragm is relatively preserved, creating that characteristic bell-shaped chest appearance. These infants also lose the ability to swallow and eventually lose all their voluntary moments. Cognition, however, remains completely normal. So like I mentioned before, these bright children trapped in these bodies that cannot move, like a locked-in syndrome. And then I think it was worth briefly comparing SMA to another neuron disease that you may be familiar with, which is ALS, or amyotrophic lateral sclerosis, with essentially being the key distinction that SMA is genetic and present from birth, while ALS is degenerative and acquired. While they both share the same final common pathway, the motor neurons lead to muscle weakness and atrophy. The clinical presentation of SMA can be organized into three categories. Respiratory signs include a weak cry and paradoxical breathing where the abdomen rises but the chest retracts during inspiration, recurrent respiratory infections, and alternate respiratory failure. Motor signs are the hallmark feature. There's profound hypotonia, often described as floppy baby syndrome, absent or diminished deep tendon reflexes, failure to achieve motor milestones, and proximal greater than distal weaknesses. Other important findings include tongue fasciculations, which are small involuntary twitching movements of the tongue muscles, difficulty feeding and swallowing, and notably completely normal cognition and alertness. That last point is clinically important because it distinguishes SMA from other causes of infantile hypotonia. SMA is now included in the recommended uniform screening panel in the US. This means that infants can be identified before they even develop symptoms, which is crucial because these pre-symptomatic treatments yield dramatically better outcomes. And studies have shown that infants diagnosed through newborn screenings and treated early are far more likely to achieve milestones like sitting and walking independently compared to those diagnosed after symptoms onset. So confirmatory tests involves genetic testing for homozygous deletion of SMN1 axon 7, which is present in approximately 95% of cases. The SMN2 copy number is also determined because it directly guides prognosis and treatment decisions. Genomic sequencing is also emerging as a first-tier diagnostic approach for children with suspected genetic diseases, with diagnostic yields approaching 50% for neurodevelopmental disorders. Before gene therapy, treatment for SMA consisted only of supportive care and two disease-modifying therapies. Supportive care included respiratory support with the BiPAP or tracheostomy, nutritional support, physical therapy, and orthopedic measurements. The first disease-modifying therapy was Nercessin, or brand name Spinraza, which was approved in 2016. And it worked as an antisense oligonucleotide that modified the SMN2 splicing to produce more full-length SMN proteins. It required intrathecal injections, which meant that it required a lumbar puncture with 4 loading doses followed by maintenance doses every 4 months for life. The second is Risdiplam, or Arisda, which was approved in 2020, and it worked by the same mechanism, modifying the SMN2 splicing, but has a major advantage of being orally taken. And it's been approved for all ages, with both of these therapies requiring lifelong administrations because they don't fix the underlying genetic defect. And this leads us to the new gene therapy breakthrough with the development of onasemnogene abiparvovec, or the brand name Zolgensema, which is a fundamentally different approach because previously it was modifying the SMN2 splicing, but now the gene therapy is delivered through a complete new functional copy of the SMN gene directly into the patient's cells. The vehicle for delivery is an adeno-associated virus serotype 9 or an AAV9 vector. And as you can see in the diagram, the AAV9 capsid is an icosahedral protein shell that packages the therapeutic gene. And this was specifically chosen because the tropisms of adenoviruses, they have the ability to cross through the central nervous system, meaning it can cross through the blood-brain barrier after intravenous administration and reach the motor neurons in the spinal cord. And the treatment is given as a single one-time intravenous infusion. And then once inside the motor neurons, they deliver the SMN1 gene, and that's maintained as a non-integrating episome, meaning it can sit in the nucleus but doesn't insert itself into the patient's chromosomes, which provides the sustained SMN protein expression without the risk of interstitial mutagenesis. In essence, this one-time infusion addresses the root cause of the disease, which is so fascinating. And then to kind of talk about how this is relevant with the trial that's been going into with the essentially the modified virus therapy. This was just a study that was conducted in trial that showed that there was a marked improvement, and they specifically measured the child's ability to sit upright, which was an unheard feature, especially with SMA disease. And then also there was a SMART study that extended the evidence to older and heavier children, and that included patients who had received other SMN therapies, which broadened the treatment population as well. So this was just a nice recap on the further evidence that was done. And with any therapies, there are always important safety considerations. So the Zolgensema is FDA approved for pediatric patients less than 2 years of age with SMA and biallelic SMN1 mutations. The dose is about 1.1 times 10 to the 14th vectors of genome per kilogram of body weight given over a single IV infusion over 1 hour. And systematic steroids, particularly a prednisolone taper, are required before and after the infusion to manage the immune response due to it being a viral vector. And the key adverse effects that were seen with this were hepatotoxicity with elevation of liver enzymes that were common and requiring regular liver functioning monitoring, with instances of thrombic microangiopathy, as well as some serious, more rare complications pertaining to cardiotoxicity and thrombocytopenia. And there are 2 critical pre-treatments that are required. First, active infections must be resolved before starting the infusions. And second, the anti-AAV9 antibody testing is required. So if a patient has elevated antibody titers against that specific vector, which can occur from a prior natural exposure to an adenovirus, the treatment might not be as effective and might need to be postponed or precluded from patients being used it. And I just wanted to create a simple little chart casing essentially the 3 drug therapies for SMA, with the Zolgensema on the far right here, indicating what the future will hold for treatment with SMA. And now with gene therapy being such a huge, crucial part, and not only in dealing with neurodegenerative diseases such as SMA, I think it was important to look into what else could be further researched in the future. So there has been talks about using different combination therapies with the gene therapy and splicing modifiers, intrathecal gene therapy for some of those older and heavier patients, and then using different virus vectors that have improved tropism to reduce the immune system response to the therapy to avoid any complications. And here are my references from everything I've done. And I hope that you learned something today from my slide. I hope you have a great rest of your day.